Good morning and welcome back. Sorry you have me for two panels in a row. Hopefully it won't be too boring for you. This panel we're looking in more depth at the government's plans for health and social care reform. I'm Stuart Hoddinott, a senior researcher here at the Institute for Government, and I'll be chairing this event. I'd like to extend a warm welcome to everyone in the room and online. Wes Streeting wasted no time laying out his views on the health service, proclaiming the NHS as broken the day after the general election. Since then, there's been a flurry of activity on health. The government commissioned Aradazai to conduct an independent review of the NHS a week after the election. That review has now reported and deemed the service to be in serious trouble. The government then launched the public consultation for its 10-year health plan, which it hopes to publish in spring next year. The precise contents of that plan are not yet clear, but we know that Wes Streeting wants to make 3 shifts: from hospitals to the community, from treatment to prevention, and from analogue to digital. And finally, the government set out the NHS's envelope for the first full financial year of this Parliament in last month's budget. But that budget leaves many unanswered questions for health and social care. Will the 10-year plan catalyse meaningful improvements in waiting times and access to care? Or will it be another reform programme that overpromises and underdelivers? How will the government fund that reform programme? Will it use next year's spending review to direct more funding to prevention and out of hospital care? And what does it even mean by prevention? Finally, since cancelling long-planned charging reforms for adult social care in July, the government has been extremely quiet on what it plans to do with the sector. Do our panellists think the government has a plan for social care, and what might that plan look like? To discuss those questions and more, I'm delighted to be joined by Dr. Becks, Director of Research and Policy at Nuffield Trust, Professor Naomi Fulop from UCL's Department of Applied Health Research, Dame Una O'Brien, former Permanent Secretary at the Department of Health, and Preet Gill, MP, former Shadow Minister for Primary Care and Public Health, and now PPS to Jonathan Reynolds in the Department of Business and Trade. Each of the speakers is going to make opening remarks. I'll then ask a few follow-up questions before opening up to a Q&A from the audience. If you're here in person, please raise your hand to ask a question, and if you're watching online, you can start submitting your questions now. I'll now hand over to Una for the opening remarks.
Okay, well, good morning, everyone, and thank you to the Institute for Government for organising such a timely conference. I think when the textbooks are written about a new party coming into government after a long break, we'll certainly be thinking that health have made an excellent start. They really have done the things that any external experts in government would be looking for: the clear ambition for change, compelling analysis of the problem, settling the industrial disputes, getting the budget out the door, and particularly I would want to highlight the very strong, clear leadership from the politicians and the efforts to bring in some new, highly capable people. So, you know, we might say so far so good before we see the, if you like, the outturn of all of this activity. Where are we now? I would say we're in a sort of liminal in-between space. We've certainly got some clarity on what the government wants to change around the NHS. We don't have the same compelling clarity around social care, mental health, or the wider population health. And I worry that, in a way, those 3 very important dimensions of health and care are going to be solved on the coattails of the NHS rather than be dealt with in their own right. We have some working details about the resources for this year and next year. There is the commitment to deliver the 40,000 elective appointments per week. That will make a small dent on the 18-week waiting time. Much more to come yet in the spending review, or phase 2, I think it's called. I just want to touch very briefly on the, shall we say, the wiring behind the plan that's underway at the moment. The Department of Health and Social Care have published the title and the leaders for the 11 working groups. And certainly all our attention will be drawn to the 4, which are about the future vision. But today we're talking about public sector reform, and we might want to pay attention to the 7 working groups, which are really going to be about how stuff gets done. And I do wish those teams the very best in trying to knit all of that together into a meaningful model for bringing about transformational change. Particularly, we need to keep an eye on the Accountability and Oversight Working Group and the finance and contracting. We now have 40 years experience of public service reform, and we've pretty much tried everything from financial control through to contracting out, privatisation, competition, choice, patient empowerment, regulation, transparency, and delegation. I have no idea at the moment how any of those tools are going to play into this new plan and what the combination of them will be. So this is a really good forum for us to sort of raise some of those issues. And then my final point is, what are my hopes for the future around the way things get done? I believe, having spent 8 years now not in government, passionately in delegation to the lowest possible level, and to the more local, the better, especially when it comes to health and care. You just cannot run a health and care system for 70 million people from Whitehall. It's just not possible. So we need to really back the structure of the ICBs and make them as good as they can possibly be. But at the same time, my final point is that we do need to aggregate ruthlessly to the centre where that is the right place to get something done. And we've shown we know how to do that with, for example, the creation of NICE 25 years ago, with the one-off conversation we have with the pharmaceutical industry, with the creation of NHS 111. So we have good experience of aggregating to the centre. And I'm going to be really interested to see how that balance between devolution, delegation, and centralisation works to get big change in the future.
Thanks. Becks.
Hi everyone. Stuart, thanks for having me. Nice to be with you all. I'm going to keep this brief. I'm a GP. Yesterday morning I was in general practice. Stuart asked me to think about what I wanted to see in the 10-year plan. And I think what I actually thought about is, how do I want to feel in 10 years in my surgery? And it's not how I felt yesterday. I want to feel as though I am delivering meaningfully better care for my patients. I don't want to feel ashamed when they ask me how long they're likely to be waiting. I don't want to feel worried that they're going to deteriorate while they're waiting for their scan. And I don't want to be a GP working in a socioeconomically deprived area, as I am, which is structurally underfunded by a system that too often directs money to our most affluent areas, leaving socioeconomically deprived areas under-resourced. So I'm going to zoom out now to the big picture, perhaps the question I was asked to answer, not how do I feel. I think there's little to argue with the government's 3 shifts. Probably many of us agree with them. The question is, what is needed to make it happen? I would suggest government needs to be bold on funding. A 10-year plan needs to look directly at how money is distributed and handed out. If we're serious about moving more care into the community, we currently have the lowest proportion of spend on primary and community service historically ever. So that needs to change. It's difficult to see how that changes with the budget. So we'll come to this, I'm sure. 22 billion sounds like a lot of money. Average, you'll have heard banded around, is sort of 4% real terms increase over 2 years. We think that once you account for non-recurrent transfers and a variety of other little wriggles in the budget, it actually works out as more like 3%. Inflationary costs for the NHS are currently running at 4% a year. Staff increases 5.5% a year. All of a sudden, that 22 billion doesn't seem like so much. So I think there are real questions about, and I know Alan Milburn had a lot to say about this at the weekend, but actually, do we need more money to be able to reform? My view is I think it's very difficult to reform without a little bit of pump priming at least. And before I move on, I would be very sad if this conversation didn't centre social care. It's what I'm most worried about at the moment. I was particularly worried about the 600 million in the budget. Social care needs immediate stabilisation and it needs a long-term plan. But giving 600 million to local authorities whilst increasing national insurance contributions and the minimum wage, great, we need the living wage for workers in social care, but we need to fund that wage. And so we're really worried at Nuffield that actually there's a risk that current policy is destabilising a sector that is currently out with the band of most of the 10-year plan. But actually, we all know that if social care falls over, the NHS will be with it. So I'm excited that we're having a different set of conversations now to the conversations we were having a year ago. But there are also, I think, some worrying undercurrents that I'm sure we'll pick up in conversation today.
Thanks, Becks. Naomi?
Thanks, and good morning, everybody. It's great to be here. Thanks for the invite, and thanks for what you both have said, which I agree with. So the session was entitled Reform or Repair, and I think we need to do both in parallel, and that's what the real challenge is, and I don't envy people who have to really get into the nuts and bolts of that, although I'm happy to contribute. So in the short term, in 2 years' time, people have to feel, it's what I call the pocketbook issues for health. People have to feel a difference, as Becks talked about. People have to feel it's easier to get an appointment with their GP. They have to feel that their auntie isn't waiting as long for their hip replacement. And if they don't in 2 years' time, we're in trouble, and we're in political trouble, actually, from my point of view. So, and alongside that, we do need to stabilise social care. Because currently 13,000 people are waiting in hospital beds for social care. That equates to 26 hospitals, and we need to be dealing with that now. But I do want to just briefly reflect on the 3 strategic shifts that have already been mentioned. So hospitals community, successive governments have tried this over many years, as Una referred to, and we need to learn from previous failures. What didn't work, why. It's not necessarily cheaper. Unfortunately, you need double running costs. You can't just close hospitals and shift resources out. You have to have both running together, and that, I'm afraid, costs money. We know that from work we've done on hospital at home back in the 90s, but more recently on virtual wards. Analog to digital, yes, so much could be done out in the NHS. Most organisations are very low base digitally, and there are a lot of gains to be made there, but it's not a magic bullet, and it's not just a technical solution. It requires expert project management, experts in procurement. We're currently looking at the deployment of AI in radiology, which I can come back to later, raises all these kinds of issues. And some of those at the top think it can be done, in 2 months, and it's actually going to take 2 years to implement in 60 trusts for all sorts of reasons. But also, in terms of the analog to digital, the patient-facing element of that needs to be thought about really carefully so we don't entrench inequalities. And again, I think it would be good to come back to that. Movement from treatment to prevention. In the context of a wider population health strategy, which I very much hope we get to, there's some low-cost regulatory measures I think we can look at of the food, drug and alcohol and gambling industries. Dimbleby published the National Food Strategy a couple of years ago, which sets out in very good, helpful, evidence-based detail about how we could have tax incentives to reformulate for sugar and salt. These sorts of measures are supported by the public. We know that from polling. Perhaps less well supported, but I think we should consider minimum unit pricing for alcohol. They've done it in Scotland and Wales. There's evidence from Scotland it does reduce deaths. Finally, underpinning all of these is the role of staff and citizens in co-producing these changes, and it chimes with what Una was saying about delegation right down to local levels. We need to involve staff and citizens, and NHS has not been very good at that historically and needs some help and support in doing that. So I'll stop there. Thanks.
Thanks, Naomi. And Preet.
Thanks, Stuart. It's absolutely fantastic to be here with this panel. Look, the Prime Minister and our government knows that one of the main ways that it is going to be judged is how it delivers on the NHS. And we've inherited a service with elective waiting lists at their highest levels, chronic underinvestment in capital budgets, record funding but lagging productivity, an ageing and unhealthy population, and other public services like local government and social care in crisis, and patient satisfaction at an all-time low. And the title of this session is Reform or Repair. And of course, given its importance and with the multitude of challenges the NHS faces, we have got to do both. The Health Secretary has acknowledged as much with the immediate injection of some £22 billion of funding into the NHS over the next 2 years, while also committing to publishing a 10-year plan for fixing the NHS due in the spring next year. So what is the new government's approach to this enormous task? Well, the government is getting on with bringing down the waiting list it was elected to fix. Clear manifesto commitment. Since July, we've already invested an additional £1.8 billion to support this initiative. We immediately ended the strikes with a pay rise for NHS staff. After the strikes, we know pulled billions away from patient care and undermined the last government's already uninspiring pledge to simply get waiting lists to fall. We've already announced £1.5 billion to fund new surgical hubs and scanners, which will help build capacity for over 30,000 additional procedures and more than 1.25 million additional diagnostics tests. This will help tackle one of the key issues that is hampering the NHS's performance, identified in the Institute for Government's NHS Productivity Report last year, which of course is about patient flow. Most fundamentally, the new government is putting flesh on the bones of the reform agenda that it has set out, which will be defined, as we've already heard, with 3 big shifts: hospital to community, analogue to digital, sickness to prevention. The first shift from hospital to community is critical to improve performance and patient flow. You could fill 26 hospitals, as we've heard, with the patients in hospital beds today unable to be discharged because there is just not the care or the quality of care out there in the community. It's more expensive to treat patients in hospital, it's less convenient for the patient, and much of what is done in hospital could actually be done closer to home. To be an outpatient, you shouldn't have to travel all the way to hospital as the default. So many of the consultations, the scans, the tests and referrals could actually be done if we want to diversify the high street, for example, in pharmacies, in opticians, in GP surgeries. That's what neighbourhood health centres would actually do, closer to people's home, enabling patients to see GPs, district nurses, care workers and other medical professionals all under one roof. There is already good pockets of practice happening around the country. The shift from analogue to digital will also be key. Yes, there are challenges, but this is really about modernising the equipment we use in the NHS so patient notes are not still being sent to colleagues on fax machines, enabling cutting-edge technologies like machine learning to help acutely diagnose cancers. But it's also about a vision of patient choice and of continual improvement and innovation. Patient choice and access could be revolutionised through smarter use of the NHS app. Innovation could be unleashed across ICSs through the better use of NHS data. That's why we've been talking about driving interoperability from the bottom up by making the NHS app a one-stop shop for health information. So health and care providers should publish into it, and all the data would be owned by the patient who could see it in one place. This would act as a single front door to personalised services that breaks down barriers between primary, secondary and tertiary care, as high-performing ICSs are already showing high-quality integrated data collection and interoperable digital systems can initiate real change. So in Cheshire and Merseyside ICS, they're now tackling winter fuel poverty by cross-referencing deprivation and fuel poverty data with COPD and asthma and multiple admissions. So community respiratory teams can get out to these patients and make sure that they're getting their winter fuel payments. If the new government can crack this issue and set a clearer, more centralised direction for future procurement of data systems so they are genuinely interoperable between providers and with wider public services, I think this could be a game changer for the nation's health. And finally, we do need to see that drive from sickness to prevention. For 14 years, there's been no joined-up plan for health. There's been an unwillingness to lead on issues like smoking, obesity, and services and institutions that promote good health that have actually been run down. We saw the decimation of Public Health England during the pandemic. We know that prevention is obviously better than cure. So why do we simply accept the billions we spend on treating diseases like type 2 diabetes, where lifestyle changes can actually help reverse it altogether? The new leader of the opposition may hate this, but public health policies like this government's commitment to legislate for a progressive ban on smoking, to crack down on vapes, and finally bring in the regulations, as we heard, on pre-watershed junk food ads, are low-cost, high-impact policies, and they take the pressure off our ailing public services. They improve health, people's health, and save lives. So as Lord Darcy wrote in his report last month, the NHS is broken, but it isn't beaten. And only by repairing, reforming, and rebuilding the NHS all at once will we be able to ensure that it's there for us for the next 75 years. Thank you.
Thanks very much, Preet. Just some questions for me before we come to the audience. Becks, you talked about your time as a GP, your experience in general practice. The service has had some industrial action over the past couple of months. It's had a contract imposed on it for 3 years in a row by the last government, and it's currently negotiating a contract beyond March next year. There are declining numbers of GP partners. But the government has been very quiet on what it plans for general practice. Why do you think that is, and what do you want to see from the government on general practice in particular?
I like to think that the government is quiet on it because they're taking time to understand this complex problem properly and come up with a comprehensive set of solutions. And I do think it is really complicated. You will all know that public satisfaction with general practice has fallen off a cliff. There are some interesting complexities to that I'd just like to point out. So, for example, access to general practice, roughly the same proportion. The public's top priority is consistently wanting better access, faster access to GP appointments, but actually the proportion of appointments delivered on the same day, 43% in the last month that there's available data for, is roughly the same as the proportion of people who say they want to see a GP on that day. People want better access to face-to-face appointments, but when you look at data that people supply to their GP surgeries at the point when they're actually wanting a consultation, a majority of people want a telephone appointment. So there are complexities here to unpick. And I think historically governments have made mistakes with general practice where they rush into thinking that fixing general practice is all about giving people access to faster appointments. So I think a little kind of thought and pause from governments is a good thing. Just to go into those complexities a bit more, funding of general practice, you mentioned collective action that some GPs have been participating in recently. I said earlier that the proportion of spend on primary and community care is at a historic low. General practice receives less than 8% of the NHS budget at the moment. It has increased in real terms, of course, over the last few years because of inflation, but actually GPs are finding that their budgets are enormously constrained. So the overall slice of the pie that goes to general practice is low and probably needs to be higher if we want general practice to be delivering the service that we think the public expects from it. Second on funding, though, within general practice, the distribution of funding between surgeries is inequitable. So there's much more health need in poorer areas of the country, but GP surgeries in the poorest quintile of areas receive on average 9.8% less funding than GP surgeries in the most affluent areas. That's in large part because we have an outdated funding formula that doesn't adjust for need associated with deprivation. So it's not just about the overall slice of the pie to general practice, it's about how you subdivide that pie. Briefly, on workforce, you'll all be aware it's harder and harder to see your GP. The proportion of appointments done by GPs in general practice has been decreasing. That's for two reasons. The number of full-time equivalent permanent GPs has fallen since 2015. Lots of manifesto commitments to boost numbers of GPs, they've fallen. But there have been 40,000 additional staff brought into general practice in other direct patient care roles. So the composition of the workforce is changing, and you'll know that if you've tried to access your GP. There are real challenges about how we best deploy the workforce in general practice. Government needs to think seriously about what operating model it wants for general practice. Stuart, you mentioned that the proportion of GP partners has decreased. In 2015, it was 67%. Now it's 49% of GPs are GP partners. So the way that GPs hold contracts with NHS England may need to evolve as GPs change their working preferences. And the final thing that I would say is that I'm really worried about the support offer for general practice. We talked on this panel in opening remarks about the importance of good management support and commissioning. I'm worried that in the shift from CCGs to ICBs, a lot of the infrastructure that supported general practice, and remember most GP surgeries are really small businesses, they don't have the big management support of hospitals and the analytical capacity that comes with that. I'm worried that that kind of got stripped out a bit when that change was made and hasn't been replaced. So we have simultaneously a really precarious situation in general practice and not that much support infrastructure to help it with the transformation that it probably needs. So my hope is that government is taking some time to unpack that and will astound us with a plan to fix it all and some funding to go with that shortly.
Thanks, Becks. That was incredibly comprehensive. Naomi, you've talked a bit about your work on virtual wards. What does your work tell us about how the government can most effectively shift care out of hospitals into the community, and what role can virtual wards play in that?
So I think, as Preet mentioned, there's lots of initiatives around the country doing this kind of work. The problem is that they're mostly ad hoc, and I think we need a strategy for how we do this shift from hospital to community, and of course it involves general practice and primary care and community care and all of that, social care. So in terms of virtual wards, we studied the establishment and implementation of virtual wards during the pandemic, which were set up for people with COVID to be able to care for people at home and then escalate them as necessary if they needed to go to hospital. There were also models looking at early discharge from hospital, which would hopefully free up beds. There are many other, since then, virtual wards, it's been a national priority, and the previous government set a target of the number of virtual beds across the country, which I'm not sure was terribly helpful. But it needs to be virtual wards need to be part of this wider package. In and of themselves, they won't achieve anything. And as I said, unfortunately, you can't close hospital beds until you've got these other initiatives up and running. You also need to change funding flows. The incentives are all about admission to a hospital rather than... So you need to get providers of community services and hospitals working much more closely together to figure that out. I've just finished a 6-year term as a non-executive director on a trust that's a combined acute and community. I'm not saying we had it all cracked, but there were things we were able to do with a rapid response team which went out, supported people in their homes. It really helped avoid their coming to A&E and admissions. So there's all kinds of things that can be done at local level, but it needs to be supported by a national strategy and funding.
That's great. Thanks very much. Una, the cross you have to bear. You were in the Department of Health during the Lansley reforms.
I knew you were going to ask me. Okay.
What lessons do you think Wes Streeting should take from that and other reform programmes? How can he make sure that this is a genuine success?
Well, I am very confident that the estimable Secretary of State has drawn those lessons well and truly already. And you can see in the working groups for the NHS plan, he's been extremely clear about no structural reform, which I think is the lesson everybody wants to draw from the Lansley reforms. I hope he's just talking, though, about the superstructure of the NHS, and I'm talking here about the commissioning and the orchestration that goes on behind the scenes, because down the line, there is going to need to be change to some structures in localities to deliver the sort of ambitions that we have. So let's just stick with, we're not going to change the superstructure of the integrated care systems with the boards and the partnerships. That is very new. We need to make it work. And I thought Patricia Hewitt did an excellent report actually under the previous government describing what needs to happen to support those organisations to be really good. And it's very early days, and some of them are already doing very well, but others are struggling, and having the management and leadership support to enable them to be good. So no touching that superstructure, but there still needs to be reform. I mean, if we look at the Penny Dash work, for example, on the Care Quality Commission, now broadened out to look at the plethora of safety and quality regulators, I think there is going to have to be change there. So it's got to be change with a purpose and not for an ideological reason, and I think that would be the best way to settle it.
Just as a quick follow-up question, do you think that as they're constituted, DHSC and NHS England are well set up to deliver reforms?
Oh, who knows? Yeah. Well, they've brought in some fantastic people. That's the first thing I'd say. You know, obviously, we've got the announcement about Alan Milburn now as the lead non-executive director. We have got a fantastic new second permanent secretary who's come from running Leeds City Council. And I'm absolutely sure that bringing that perspective into the department will be very, very strong. We have an outstanding, and long may he last, Chief Medical Officer in Professor Sir Chris Whitty. So, I think we've got good leadership there. All the departments, and the Department of Health and Social Care will be no exception, are going to have to take a very tough look at their numbers, their capability, and their organisation, because they will be not included in the budget increases. So that is going to be quite a tough ask for every department. So I think the jury is out, to be honest, but we shouldn't just look to the department to be the leader. I want to see the leadership distributed more purposefully around the country. Trying to get everything done from the centre just won't work.
Great, thanks. And Preet, finally coming to you. You currently work in the Department of Business and Trade, so you're seeing this happen from the outside. How are you viewing the health mission from outside DHSC? How does it impact work done in other departments? And also, how does the mission that you're more interested in, more focused on the growth mission, sort of require health to support it as well?
Well, look, I mean, the growth mission is really, really important, and the Department for Business and Trade and Treasury will drive a lot of that. But of course, what we do in the NHS across all the 5 missions really contribute to growth, and there are 3 million people sitting on those waiting lists, whether they're in pain or whether they're waiting to get a treatment or an operation, that cannot go back into work. That is not going to help grow the economy. That's why the waiting list had to be a priority, reducing those down. And we've got to make sure that, we're supporting people to get back into work, because the state is obviously paying far more than it needs to. But look, there was lots of initiatives, and I'm sure at some point you're going to come and talk about social care, because I think that's the elephant in the room. And I think the government is right to take its time. Previous governments haven't been able to address this. And similar to the industrial strategy, which is about legislating for it, whatever we do between now and our consultation has got to be cross-party consensus around this. We cannot have that when there is a change of government, they suddenly unpick what we are trying to do and achieve. We are never, ever going to deliver social care if we constantly, as we've seen in the last 14 years, just have continual change at the top. And we've got to give some very clear direction. The principles of, having care at home, for example, well, that requires a workforce to be able to deliver a lot of that. So you do need the district nurses, the physios, the OTs, etc. There's been lots of good pockets of practice around the country, around, councils, for example, buying wards in hospitals, or having a other facility of having discharges and then being able to put care packages in place. But of course, this has become much, much more complex and difficult. And so, councils are already also giving up providing residential care. They know how difficult it is. It isn't just about having that access to care, and the private sector will provide a lot of that. But what's the quality? What do we expect? And are we getting, are people getting not only choice, but value for money? Because, we see from CQC reports about, lots of people going into homes and pretty much really being contained there, as opposed to it being a great place. In my constituency, the private sector provide, if you've got the money and and you can afford it, the quality of care is phenomenal, and the stark inequality that you see. So there's so many things that we have to do in terms of actually getting people out of hospital back into the care. What does that actually look like? And we've got the opportunity to really look at what's been said before us, because this isn't about reinventing the wheel. There's been so much reports done over decades that have already given us lots of really good recommendations. So we just really need to be able to go through that and take the things that we can deliver now, and then look at the medium and the long term and really build a consensus around this and take the British public with us, because I think fundamentally this is about patients, and patients really need to be at the heart of whatever it is that we provide, because that sense of dignity, that choice has got to be really at the heart of what you build around that.
Great, thanks so much, Preet. I'll now come to the audience for questions. If you could raise your hand if you have a question, we'll bring a microphone to you. And can I ask that you please keep it to a short, concise question rather than a long, rambling statement. We'll take 3 questions at a time. The lady here, and yeah, sorry, go ahead.
Hi, thank you very much for the panel discussion. My name's Hebe. I run Telescope, a social enterprise connecting policymakers with frontline practitioners. And I wanted to ask a bit about what you were just touching on at the end there in terms of the move from strategy and kind of vision to implementation. You've all touched on it in different ways in terms of delegation. There have been lots of discussions about, and lots of, as you say, lots of recommendations. What can this government do differently to empower frontline practitioners to really make that change? And what structural or incentive changes might need to happen in order to give those expert practitioners what they need to do their job well?
Great, thank you. There's a gentleman over there. Thank you.
Hi, Tom Hughes, NHS England. So the previous Labour government set up walk-in centres, and there were 230 of these, and it took about 3 years to set them up and about 20 years to close them down because they added activity but didn't actually add health benefit. So the question is, what should the government do to ensure that all these exciting new initiatives actually provide value for money?
Great, and then one more here.
Hi, I'm Oliver. I work in the House of Lords. I had a question about digital projects, and you mentioned that, Preet, as a way that the NHS would improve performance, but we've seen in the last year alone with Synovis and Epic, two major digital transformation projects that have been implemented that have actually added to the litany of issues the NHS have had to deal with. I mean, Synovis, the crisis recently with data breaches, and Epic as well, they're costing trusts millions of pounds and causing significant delays. Certainly Synovis delayed a lot of projects in the trust that I work with. So how can you be so confident the NHS can provide value for money with new projects, given that they failed to provide efficient, safe and timely projects in the last year?
Great, thank you very much. So we have a question about strategy to implementation, how the government can support frontline staff, looking at how new initiatives can deliver value for money along the lines of the walk-in centres, and finally, how can we get value for money from digital transformation? I'll come to Preet first, and we'll go along the panel.
Look, I think this government wants to do things differently. It's already very clearly indicating how it will do things differently. And we've got to really be talking to those frontline staff who are at the delivery. And I think I hear this from GPs all the time who say ICPs don't actually talk to them when they're thinking about where that funding goes and addressing inequalities. I mean, ICBs are supposed to really be mapping out in the regions what exists, where are the gaps, how do we actually, address some of those. So I think, we've got to do a review of ICBs. There is so much inconsistency in terms of how they are functioning. There's some really good ones, there's some really proactive ones, and there are those that, will probably be struggling in some respect. So I want to see frontline staff really feel valued, feel that actually this is the government that's listening to them, and it wants to do things differently. And it's about, taking the time to be able to do that properly. And I hope already, especially the sector has begun to see Wes is real clear about that, and bringing in new people and not afraid of making the changes that we need in order to get the work done. We have some phenomenal people in our NHS, I have to say. Many tell me that their skills are never valued, or they're never spoken to about actually what needs to happen. And I just really honestly think we need to start doing that a lot more. I think you're right on the walking centres. You've got to start, what is the outcome that you want and what is it that you look for? So you've got to start at the end and then work backwards in terms of what it is then that you're trying to establish. I mean, there are still some of those centres around. I see them in Birmingham, and my question to the ICB is actually, this is the kind of, if we're looking at community models, these centres should be repurposed, because actually if you can put more of our community care, what that looks like, and public health working together, co-located, then we are going to be able to work far more better. But I definitely think it has to be evidence-based. We already know what the evidence says in terms of research. We've got some great academics, universities doing some phenomenal work. We know what's happening in places like Singapore and other countries, and Wes has already been to visit and look at what are the things that we could very quickly implement here. And on the digital, look, I mean, you have to ask yourself what on earth has been going on with NHSE for the last 14 years. They should have been doing the horizon scanning. It's not right that trusts are left to, at the moment, trust procure, commission, do a lot of things themselves. There needs to be a lot more joined up at the top, and they need to be working together. And it is about looking at what is out there that's working, and what can we deliver, and how do we bring the best people together to deliver on a project, there has to be leadership and direction from the top. We haven't had that really. And so, you know, Wesley's clear shift from analog to digital, absolutely right. Is it going to be challenging? Yes. Will it take time? Yes. But we can do it, you know, and we've got to do it in order to bring about the efficiencies that we need to see and the reform within the NHS. Thanks.
I've got nothing to add, but I'm hoping that Naomi will touch on the clinician-led work on stroke services in London, which I think is a really powerful example. Yeah.
Sure. So the question about how do you empower frontlines, I think that's absolutely key. And I think there's two things that need to happen. One, there needs to be a big cultural change away from blame, which we've had for 30 years. And I'm not so sanguine as Una about some of the people being brought back from the past because they were part of the centralised command control stick thing. But anyway, I think there needs to be much of that big cultural change right from the top through to the bottom. And secondly, I was very pleased that the Darcy report said we need more managers. Not popular with some of our tabloid newspapers, but we do. If you're going to support frontline staff to make the changes that they want to make, you need good project management. You need those managers. To touch on what Una was mentioning was some of you will know that London and Greater Manchester transformed their stroke services a number of years ago, whereby they centralised services for people with acute stroke. So you might be taken in an ambulance and driven past your local hospital to a centralised hub, which is called a HASU, hyperacute stroke unit. And in London, that was really clinically led to the point that the lead clinician actually gave up his stroke service for the benefit of the whole of London. And the other point about that is, which relates to moving from hospital to community, is it is not popular to close hospital wards or hospitals, as you'll know, anyone that's tried to do it. And so there is a difficulty here when we talk about all this involving citizens, as I do, is that they don't always they want the walk-in centres. So if you're going to say, you know, we're going to give patients choice, well, my choice is I want a walk-in centre. And they said, well, actually, we've crunched on it, it's not value for money. You know, so we need to work through those things, and we need to bring people with us to show what can be achieved, which were better outcomes for patients in London and Greater Manchester.
Great. Becks, do you have anything?
Just to add on the value for money, I think, so there is part of this is about contracting and how good you are at that. Recent evidence suggests some departments may benefit from re-examining their approaches, but focusing more on the policy making. I love working in kind of think tank space because it allows me to take rigorous academic methodology and apply it to policy and political cycles. There is an enormous wealth of evidence in this nation that I think isn't really tapped into by policy making. And when I came into this world, I was interested to see how disconnected actually they are. So I think partly this is about, Preet, you've talked about government taking a different approach. I would love to bring back the experts. Let's get the rigorous academic evidence into policy making and use that to inform the decisions that are being made. Then I think there is part of this for me that is about evaluation of services, and too often I think we actually don't know whether things work or not for too long. Well, sometimes full stop, and sometimes not until far too long after the fact, because we didn't build evaluation into the process. Good evaluation should be conceived at the point that a project is initiated. It should be properly funded, and it should run through the life cycle of the project and beyond. And I think at a government level, I would love to see an approach that encompassed better evaluation built into the public policy, into the new ideas for the 10-year plan, because then we would understand much faster what was working and expand that, and what wasn't working and stop doing that. And just finally, to your point on patients, something that I would love to see coming out of the 10-year plan process is a proper conversation with the public about how you prioritise in the context of scarcity. We don't have enough resources to deliver a utopian health and social care system, but a conversation that I think is lacking is, well, then what do you prioritise in that context? And do you want the walk-in centre, even though there might not be much evidence for it? Do you want the expensive cancer drug? that's a conversation that I don't think is happening and would love to see be on the table a bit more.
Thanks, Becks. I'd like to encourage anyone watching online to submit questions through Slido, but we can take another round of questions from in the room. We have a question down here.
Thank you. I'm Sam Mercadante from the National Council for Voluntary Organizations. Becks, you've talked quite a bit about deprivation, and Preet, you touched on inequality, and I wondered what everyone on the panel thought about the lack of a mission on poverty in terms of driving preventative health and social care services.
Great. We have a question over here at the front.
Thanks, Steve O'Neill, UCL. Obviously, UCL likes to bring people together to discussions. How can the government and NHS come together to create a consensus around the reforms that are needed, whatever they end up being?
Great, thank you. And then the gentleman directly behind. Thank you.
Neil Brady. In his original report for Gordon Brown in 2008, Lord Darcy said all of our changes in his white paper then should be locally organised, patient-centred and clinically led. That made great sense at the time in terms of encouraging morale amongst clinicians. I'm sure it did, especially in the changes that happened with stroke services, for instance. And the aspects of devolution in terms of local organisation, devolution to regions and the mayors, also needs to, I think, be taken into account. What are the panel's views on those three themes?
Great, thank you. So we have a question about the lack of a mission on poverty and what the impact is on the health and social care system, how the government and the NHS can create support for their reforms, and the panel's views on devolution and clinician empowerment. On the first one, the mission on poverty, I'd also be interested in the panelists' thoughts on how the government or how the DHSC can try and create cooperation on the wider determinants of health, the levers for which generally sit outside the department in other departments.
I can take that.
You want to go that one, Una?
Yeah, or if I could just pick that one up. You know, really Whitehall is very siloed, and people get the health and care system is absolutely enormous in the and if you work in the Department of Health and Social Care, to get your head around the area of work you're in and the system within which you're operating is challenge enough without having to think about relating to people in other government departments. So it's difficult, and that has to change. We can debate the actual number, and I know there are different analyses around, but it is now well understood that somewhere between only 10 and 20% of the health of the population can be derived from the health system. And actually what drives health and sickness is the situation in which we live, our housing, our employment opportunities, our social relationships, education, the way infants are cared for and treated. We know that these factors very powerfully affect health and drive health inequalities. It's a compelling argument for health in all policies, something that I pushed for very, very strongly when I was at the Department of Health, which unfortunately has got translated into a tick box 3-page document called a health impact assessment that gets done in other government departments. So it really is crying out for change. I think the mission board is an opportunity to do this. And I know that this is on the agenda of the health mission board. What I'm not seeing is health really on the agenda of the other 4 mission boards. There's a chance to shift the dial on this. It absolutely has to change, because otherwise the drive for spending in the health system is just going to be inexorable. So I'd completely agree with the point that you're making.
Can I just pick on that? I think, you know, coming back to the social determinants of health is really, really important. And as you've said, it is about poverty, it is about poor housing, you know, your diet and so many things. And so the government has set up the poverty task force, and the idea is that cross-government working is really, really important. And so each department meeting together and looking at what they're doing to alleviate poverty, I think is really important. We have got some really good social prescribing models though, and I think, you know, we've got to remember, a lot of people when they go to their GP surgery, it isn't always about health, it's about the poor outcomes as a result of their social situation. And Carri's medical practice in my constituency, for example, is a phenomenally run GP practice, because it's really embedded and rooted in its community, and it goes out there and does so much outreach. And that's the difference a lot of these practices can make. So I think, you know, the role of the voluntary organisations, shouldn't be discounted. I mean, they have a huge role to play in the wider sort of integrated care system. I think government and NHS, I think this is really important. I've only been in Parliament for 7 years, and trying to see how we can build consensus and work together can be a challenge. I think, you know, this is where NHS is something that we do need to come together on, and I think this is what the British public would also want on the big issues, that there is better consensus, because what we're talking about, the future of our country and the future of our populations fundamentally, and we want to get it right. We all care about the people that we serve, and so I think there is an opportunity. I think, you know, our Prime Minister Keir Starmer has made that very, very clear, that he's open to addressing these issues, putting party politics aside, for the good of the British public. And this is one of those agenda items, you know, that I think we can start to see a lot more closer working together. I think what Darcy said then is very relevant today. And I wouldn't change anything. You know, we have got to see changes. We've got to see more local organisation. That's what the role of the ICBs is supposed to be. It should be absolutely patient-focused and clinically led. But far too often, the patient's voice is lost, and it's not clinically led, because we're not always listening to clinicians who are the experts, who do actually know what they're talking about. And it's because there's a system here that is telling, you know, whether it's NHSE or NHS in the regions, pretty much telling clinicians and patients what they have, and they've got to, you know, manage what the resources they have in the area, as opposed to looking at, well, what is the greater need? What are the top 5 killers? What does the data tell us about the region? And then, you know, the authorities in, how do we use that data then to direct and target our services? How are GP surgeries preventing, knowing their cohort of patients that go into hospital? How do they prevent falls out there? You know, this is the sort of stuff when I was certainly in social care back in the day. That's the kind of work that we were doing. It was much more partnership approach, and partnership meant more than just sitting in a room and ticking a box. It actually was about people who knew the patients that they were trying to serve and wanting to make that fundamental difference and shift.
Can I just pick up on the clinically led and unpack that a little? So it depends who we mean. So some clinicians have more power than others. And if we really want to move services from hospital out into the community, the clinicians that have the power are actually in the hospitals, and ones in the community are much less powerful. So I think we need to unpack that a little, and in building the consensus, have some difficult conversations with the public around, absolutely, about setting priorities, but also with the workforce.
Thanks, I mean, Becks.
Yeah, Sam, I couldn't agree with you more on poverty. I think it underpins so much of this. I think it's very hard, for example, to see how government meets a manifesto to halve gaps in healthy life expectancy without fundamentally acting on poverty, causes of poverty. And that, of course, Una, as you say, requires a cross-governmental approach. I just wanted to pick up briefly. I'm not sure whether we've mentioned public health on this panel yet, but I think it's fundamental and yet again at risk of being neglected. It wasn't centred within the most recent Darcy report. I would like to see more of it in the 10-year plan, but of course, since it sits directly outside the remit of the NHS, yet again, there is a chance that it isn't. There was a 21% cut in the public health grant from 2016-17 to 2022-23, despite a bump for 2 pandemic years. Public health grant funds so many vital preventative services, from sexual health services, drug and alcohol services, you know all the ones. Without that being fixed, I find it difficult to see how, we can continue to talk about the NHS and social care, but we have to fix public health as well, and that requires targeting resources to the poorest areas. Poor health is, of course, so associated with poverty, but where has the public health grant been cut most over the past decade? In the poorest areas. And that's, of course, also partly to do with mechanisms that local councils can use to raise funding as well. So just wanted to bring public health back into the equation. And just on your point about consensus, somewhere I would love to see this government actively working to build consensus is on social care. I find it really interesting. So, for example, I think there is a collective approach, for example, that we think that childcare is something that we should invest in as a state. We don't seem to be building the same consensus yet about social care and why we should be investing in social care. So building public and political support and then for creating a political narrative around why we as a society need to invest in social care seems like a kind of fundamental stepping stone to some of the reforms that in the medium term we absolutely need, whilst in the short term government could be a little more proactive in shoring up social care right now.
Thanks so much. I'll just pick up on something, and it's a question that's come in online as well. With the focus on shifting focus prevention and towards improving relationships between acute care and social care, how do we improve relationships between the NHS and local authorities who are also responsible for public health?
Well, there's a complete wide variety of relationships as you go around the country. But I've not yet met a chief executive from a local authority who does not want to get closer to and work alongside the health and care system, the health system. Obviously, local authorities are responsible for the delivery of social care in their area. So they are absolutely desiring to work more closely. Some of the mechanisms that sit beneath that relationship need to be really reformed, particularly where money sits, where decision-making sits. I'm really interested to see how the partnerships work. I mean, we know that we've got local authority chief executives on the integrated care boards. The wider partnerships in each locality, which involve the voluntary sector and other partners and businesses and so on, are absolutely crucial to being able to build a collaborative working. But I think there's a lot that could be done at the level of how the financial rules work, because a local authority is legally required to have a balanced budget. NHS budgets are, let's say, a little bit more flexible. This creates rubbing points between the two, and we need to have potentially more pooled budgets and a better shared operating model that enables them to care for their collective population.
Thanks. Any other very brief thoughts on that at all?
I would just say there's a big challenge for local authorities because the Overview and Scrutiny Committee, a lot of times the members that sit on there won't always have the knowledge and the understanding of the wider ICS system that's being operated in the region. And also probably the power imbalance of actually how do they call in decisions and how can they effectively scrutinise. And I've always said that they ought to have an expert panel made up of people from the local area to make sure that the information that's being shared with them, that they can absolutely challenge back. We do see issues, especially in sort of secondary care, whether it's whistleblowing culture, patient safety, and where do patients go, the patient voice in terms of being able to escalate those concerns. As a local MP with the largest trust in the country, I have a lot of that, and I have a lot of the health staff that probably live in the constituency as well as the patient. And so for me, I take an interest in this area because it's been my background as well, that I always want to make sure that we don't lose sight of the patient, but equally those that are trying to hold to account the system are well equipped to be able to do so. And I do see that that is a big challenge. People are very busy. It's not easy running local authorities either. And there is a lot of, one thing I've learned just doing the previous role, my gosh, the profession is so complicated and complex, especially financially, as to how, where funding comes from. So this is not an easy area to navigate. And I do want to see councils utilise universities and the research and the expertise that exists within there locally to be able to really sort of challenge.
Thanks so much. Unfortunately, we've run out of time, so I have to wrap up there. But thank you to our 4 excellent panellists and to all those who have joined both in the room and online. I'd like to have a round of applause. Thank you.